Greetings and thank you for joining us. My name is Heather Forgione, Program Manager for the Lankenau Heart Institute Women's Heart Initiative, part of Mainline Health. The Women's Heart Initiative program was developed to encourage women to learn the truth about heart disease and the risk it poses, and to use this knowledge to make informed decisions with health care provided to get the best and equal treatment to live healthier lives. We are all here tonight to discuss an important heart health topic, understanding how statins impact heart disease in women. Did you know that women are less likely than men to be treated with cholesterol-lowering statins? In fact, women are also less likely to get them prescribed as guideline recommended intensity levels. Women and men have different beliefs about the role of statins in relation to cardiovascular disease. Women are more likely to worry about having a heart attack or stroke, yet less likely to believe that having high cholesterol can contribute to one. Today, I have the pleasure to introduce an amazing physician from Mainline Health. Dr. Eric Kelly is a cardiologist for the Lankenau Heart Institute. Dr. Kelly evaluates and treats the full breadth of general cardiac conditions. He has a special interest in preventative cardiology and is a certified specialist in clinical lipidology with experience leveraging the late diagnostics and therapeutics in the management of cholesterol disorders. I want to welcome you, Dr. Kelly. I truly appreciate this. I know we had some technical issues prior, but again, thank you so much for your time, and we're really looking forward to this webinar. Thank you again.
Great. Well, thank you so much, Heather, for the introduction. It's a real honor to be able to speak with everyone. And again, would have loved to been able to give the talk live, but again, we apologize for some of the technical difficulties this evening. So Heather, you can go to the next slide. So, this is a big topic, as you might imagine, cholesterol management in general, and specifically in women. So I will try and give you just an overview of this topic. And what we'll do is start by just defining the problem, which is the risk of cardiovascular disease in women. And then we'll talk a little bit about some of the differences between lipid metabolism in women and men, which is, I think, an important thing to understand, and it helps explain, some of the differences in the way cardiovascular disease presents, particularly later in life in the case of women. Then we'll talk more specifically about statins and some of the data for statin therapy in women specifically. And then we'll finish by taking a little bit of a deeper dive into some of the facts that Heather presented at the beginning here, specifically that women have been shown to have worse cholesterol control than men, and it's a multifaceted problem, and we'll dive into that in a little bit more detail. All right, next slide, Heather. All right, so let's talk about cardiovascular risk in women. So as I think perhaps some people on this webinar may know, heart disease is the leading cause of death for women in the United States. Depending on the study, it's right around 1 in 5 women will die from heart disease. And cardiovascular disease, actually, it kills more women than all forms of cancer combined. So just sort of looking at this staggering statistic in a slightly different way. So about 1 in 16 adult women have coronary heart disease. And the menopause transition really accelerates this risk. And we'll talk about this a little bit more later in the talk. But this is an important sort of milestone, certainly when we talk about cardiovascular risk in women. And as I said, we'll talk a little bit more about that in the coming slides. And perhaps the most concerning statistic of all of these is actually that only 44% of women recognize that cardiovascular disease is their greatest health threat, that it's the greatest, the highest or leading cause of death in women. And so certainly we have work to do to make sure that this number goes in the right direction with time. It's, I think, one of the most important things we can do. Next slide. So not only are those statistics staggering, but when you actually look at sort of the traditional risk factors for heart disease, women unfortunately actually have worse outcomes compared to men. So when we look at patients with diabetes, women actually have increased cardiovascular risk compared with men with diabetes. Similarly, when you compare women with high blood pressure to men with high blood pressure, women have an increased cardiovascular risk and increased mortality relative to men with high blood pressure. And we've come to learn that inflammation of various kinds is very detrimental to cardiovascular health, and it's a risk factor for cardiovascular disease. And women have a higher prevalence of autoimmune disorders that lead to this inflammation in the body. So again, an important thing to keep in mind. And then finally, what we'll be spending most of our time tonight speaking about is cholesterol. And this point's already been made that there's less cholesterol-lowering medication used in the treatment of women. And so we'll delve into that a bit more. But I want to leave this section with a little bit of uplifting news, hopefully, or an uplifting fact, which is, studies show that most cardiovascular disease is actually preventable. So, people listening to this talk and going to see their doctors to talk about this important topic, you're already, ahead of the game. And I think that this is an important thing to keep in mind, is there's so much that we can do to change the statistics I just commented on. So I'm very glad that so many of you are on listening to this talk. Next slide. All right, so let's talk a little bit about cholesterol metabolism, and specifically kind of looking at the differences between cholesterol metabolism in men and women. So before doing that, we'll sort of start with just a general overview to make sure everyone's kind of on the same page here. So what is cholesterol? We talk a lot about it, but what is it? So it's kind of this waxy fat-like substance. And your body makes it, but also it's found in a lot of foods that we consume. So you get cholesterol through both means. And your body actually does need a little bit of cholesterol to build cell membranes, to make vitamins and hormones of various sorts. So some cholesterol is needed. Next slide. But too much of it's not a good thing. And so over a third of patients in the United States have high cholesterol, and too much cholesterol is a problem. So you need a little bit, but too much is a big problem. And the reason is, next bullet point, high cholesterol is an important risk factor for heart disease, as I think probably most people listening have probably heard about. But importantly, lowering the cholesterol reduces the risk. And so that's kind of what we're going to be talking more about with regards to some of our medications. LDL cholesterol is one of the components that you would see in your typical cholesterol panel. And again, just to sort of define these terms, make sure everyone's on the same page, the LDL cholesterol is what we would classically think of as the bad cholesterol. Just try and, you can remember the L standing for lousy, or you want that number to be lower. And the reason it's bad is that it builds up, or sort of leads to the buildup within arteries that can lead to artery narrowing. And that buildup is called atherosclerosis. And again, that process and atherosclerosis is what leads to heart attacks, strokes, and other vascular disease. HDL cholesterol is, on the other hand, is what we would consider the good cholesterol. Again, H for healthy, or for higher levels being better in general. And the reason it's considered good cholesterol is it carries that bad LDL cholesterol away from arteries, where it can then be broken down by the body. And so studies have shown that in general, patients who have higher HDL levels are at a slightly lower risk of heart disease in general. And so typically higher HDL is better. And then finally, triglycerides are really how most of the fat in the body is stored. And just like the LDL cholesterol is bad, we've come to realize, you can go to the next bullet point, Heather, high triglyceride levels are also a risk factor for heart disease. And so it's an important thing that to keep in mind when we see patients and evaluate patients. Their triglycerides matter as much as the other parts of the cholesterol profile. And these can be high in various types of patients, but particularly patients struggling with obesity or diabetes tend to have higher triglyceride levels. So with that as sort of a baseline, so now everyone sort of knows the terminology or the lingo, let's talk a little bit about some of the differences in cholesterol between men and women, and look at differences in cholesterol over a woman's lifetime, which I think is also important to mention. So there are important sex-specific differences and hormonal effects that really account for this difference in cholesterol metabolism between women and men. And the hormonal effects specifically are what really result in favorable cholesterol numbers in general for women during their reproductive years. And what that means is that women tend to have higher HDL cholesterol, or that good cholesterol, during the reproductive years, and lower triglycerides and LDL cholesterol, those bad particles that we discussed. Unfortunately, those benefits and those beneficial numbers tend to diminish a bit in the postmenopausal state, again, primarily related to the changes in hormone effects. And as a result, after menopause, we tend to see an increase in total cholesterol and LDL cholesterol and a decrease in the HDL cholesterol. And so if you can see it there, the small chart down at the bottom, this is just a chart representing what I just mentioned, which is that this is looking at total cholesterol levels in men and women. And you can see women for much of their reproductive years, on average, will have much lower total cholesterol than men. And then around the menopausal time period, those numbers really increase fairly dramatically in some cases. And so it's just an important thing to keep in mind. And this is, again, part of the reason why we tend to see heart disease manifest slightly later in life in women compared with men, is this difference in the cholesterol numbers with time. So now let's take a little bit of a shift and talk a bit about our medications that we use for cholesterol treatment. So statins are the class of medication that is most commonly used to treat high LDL cholesterol levels, high bad cholesterol. In all of our cholesterol guidelines, it is really the first line therapy. There are many different drugs in this class that you may have heard of. And the reason that they're prescribed and the reason that they're first line treatment is there are many studies that have shown that reducing LDL cholesterol through the use of statin therapy reduces cardiovascular events, so heart attacks, strokes, and the like, and reduces death as well. And so this graph here is just a way to show that, many studies and lots of our data have shown that as you reduce LDL cholesterol, which is on the x-axis there, as you reduce the LDL cholesterol, you reduce your likelihood of cardiovascular events. So you reduce your likelihood of heart attacks and strokes and so forth. And it's this very clear relationship that's been shown in multiple studies over time. But the issue, and part of the reason we're talking about this in this forum is, next slide, unfortunately, women have been underrepresented in clinical trials across cardiology and specifically with regard to trials of cholesterol medications. As you can see here, dating back, really as far as you look, women have been underrepresented in these trials. And the challenge that presents is that trying to draw conclusions for women specifically can be challenging when they're underrepresented in many of these trials. So next slide, please. So typically when we look at cholesterol medication trials, there's sort of two big buckets. One is trials or studies that look at the cholesterol medications in patients who are at high risk for heart disease, but who don't yet really have it, meaning they've never had a heart attack or a stroke, but they have risk factors. The other big bucket is in patients who have already had a heart attack or a stroke, and that's called secondary prevention. And we'll get to that on the next slide. But when we look at the studies that have evaluated the cholesterol medicines statins in women who have risk factors for heart disease, but do not yet have heart disease, the challenge we find ourselves facing is that many of these trials did not include enough women or report separate results in women to draw definitive conclusions on the efficacy of statins in women specifically. These trials generally, and their top-line conclusions are very positive, and hence the reason we use them to reduce the likelihood of heart disease. But when you ask the specific question, did women specifically benefit in these trials? Oftentimes it's hard to answer that question given that there weren't many women in a lot of these trials. With all that said, some of our latest trials, some of the newer trials that have been done, fortunately did have enough women to draw more definitive conclusions that indeed these medications, these statin medicines, result in similar benefits in both women and men. So I wanted to sort of lay this out to say that, you know, we do believe that the benefits should be similar in women and men, though unfortunately, just because of the fact that women have been underrepresented in these studies, we don't have as much data for this fact as we do for women who already have established heart disease. And so we'll talk about that on this next slide. So when we look at the studies that have been done in patients or women and men with established heart disease, otherwise known as secondary prevention studies, the evidence is far more clear because we have more data to essentially say that women and men benefit essentially equally from the use of these cholesterol medications. And specifically, it's in really every way that we have looked at the data. So both women and men have reductions in cardiovascular events from statins, and we know that higher intensity statins or higher doses of statins typically reduce events more than the low intensity or moderate intensity statins. And so those facts hold true both in men and women in these studies. So we just have a bit more data to extrapolate differences in women and men in patients who have actually had heart disease. All right, so now let's talk a little bit more about, you know, what we were alluding to earlier, which is that, again, unfortunately, women have been shown to have suboptimal cholesterol control relative to men. And so let's delve into that a little bit more deeply. So this is a multifactorial problem, right? There are lots of potential reasons why we see this time and again in studies looking at differences in treatment patterns between women and men. And here are some of them. So there's evidence that there are fewer statins prescribed or appropriately utilized in women relative to men, that non-adherence to cholesterol medications or statin medications is higher in women, that we as medical professionals often underestimate heart disease risk in women relative to men. We'll talk a little bit about the limited treatment options during pregnancy, and then finally the side effects from the medications. So we'll go through all of these. So lower statin prescription and utilization in women. So this was, I think, mentioned during the introduction by Heather. So many studies have shown that women actually receive less aggressive lipid management than men. And women are less likely to be prescribed any statin relative to men. And even if they are prescribed a statin, they're less likely to receive that statin at the guideline recommended intensity. And so as a result, women often have suboptimally, their cholesterol numbers are not as low as they should be based on their cardiovascular risk. So this is certainly a big problem. Non-adherence or not sort of taking the medication as prescribed is also an issue worth mentioning. So adherence to these medications is lower among women. And there are many thoughts behind why this could be the case. One is that women on average take more medications than men. That's what polypharmacy means, or that multiple medications is what polypharmacy means. And so, you know, the more medications you take, potentially the less likely you are to take all of them all of the time. There are thoughts that certain psychosocial factors that afflict women more than men could also play into this adherence issue. Furthermore, caregiver responsibilities, whether that be, you know, children or friends, parents, other family members, often disproportionately fall to women. And there have been studies actually showing that this is a very clear reason why medication adherence differs between genders. And then concerns about safety and efficacy. So multiple studies have shown that women disproportionately have concerns about the safety of these medications, as well as concerns about the efficacy of these medications. And so hopefully I've been able to alleviate some of the concerns about the efficacy piece. These are effective medications. And we'll talk a little bit more about the safety component as well. But certainly this is thought to be a big part of the reason why adherence is different between women and men. Next slide. So many clinicians actually underestimate risk in women as well. And so clearly, if you're underestimating risk, your prescribing of these medications may differ between genders. And so there have been some clever studies where they take a group of physicians and present two patients who are essentially the exact same in every risk factor in every medical condition. And one is a middle-aged man and one is a postmenopausal woman. And the physicians in general would categorize the male patient as higher risk and sort of treat them more aggressively than that postmenopausal woman. In any event, it's an important thing really for us as providers to keep in mind, and we need to educate ourselves and our colleagues about this fact to help close the gap in this regard. So limited treatment options in pregnancy, and specifically concerns about giving these medications to women of reproductive age, can also be a challenge or a barrier. So statins traditionally have been contraindicated in pregnancy, and until recently, the FDA considered it a Category X, so really a drug that cannot be used in pregnancy. The guidelines from the FDA have been tempered a bit. And that's kind of what that headline that I note there is about. But in general, it's typically still advised that pregnant women should not be on statin therapy. And so again, this just plays into the discrepancy in prescribing. That again, it's been shown quite clearly that providers are more hesitant to prescribe these medications to someone of reproductive age. And then finally, let's speak a little bit about side effects. So the clinical trial data actually reports a fairly low incidence of side effects. Very few side effects reported, very low percentage chance of having side effects. But I think those of us in this field and several like real world studies, as we would call them, show that the rates of side effects are actually quite a bit higher than what would be reported in these clinical trials. And next bullet. As you might imagine, statin intolerance or patients who suffer from side effects from multiple statins, patients who are statin intolerant are at higher cardiovascular risk. Again, this makes sense. If you're not able to tolerate a medication that is going to reduce your cardiovascular risk, your risk is very likely to be higher, and that has been shown really time and time again. And when we talk about statin side effects, that could be a talk unto itself, but suffice to say that the muscle symptoms are the most frequent side effect, and certainly the most frequent side effect that leads to discontinuation of medication. So well over 70% in most studies show that the muscle side effects are the most frequent cause of discontinuing medication. And unfortunately, women are disproportionately affected by these drug reactions and adverse reactions. Studies have shown that women are twice as likely to discontinue statin therapy, and their risk of muscle side effects is 50% higher than in men. And there is certainly a data to show that cholesterol medicine, statin medications can increase glucose levels, usually quite modestly, but women are disproportionately affected by this increase in glucose levels on cholesterol medications. And here again, there are several sex-related factors that we think contribute to this difference in side effects in women versus men. One is smaller body size in general. And on average, a higher proportion of body fat. Both of these things can affect the way that these statin medications are metabolized and work through the body. And furthermore, because of some hormonal differences, there can be changes in the way that blood flows to the kidney and the total amount of water within someone's body. And here again, because of these differences, these cholesterol medications can be metabolized slightly differently in women compared with men, and we think likely contributes to some of these differences in side effects. And so some other risk factors, again, that we think about: lower body mass index, and older age, and reduced muscle mass, are all things that make women more susceptible to these adverse effects in general than men. So I hope this was a helpful overview, again, of a pretty large topic, but certainly one that warrants talks like this, and certainly really happy that we had the opportunity to present it here. I would just summarize and end today by saying, again, heart disease is the leading cause of death in women, something that we need to continue to share and make sure that everyone is aware of. Women are underrepresented in the clinical trials of a lot of medications, and the cholesterol medications are no exception to that. And with that said, again, I would underscore that we really have good data to show that these medicines are beneficial in women with heart disease, as well as those at risk for heart disease. Just understanding the amount of data we have in some of these studies or some of these populations is not as great. Because of the underrepresentation. Women receive less aggressive lipid management than men, as we've discussed. And then similarly, there's this disproportionate effect of adverse reactions in women versus men. So I would be certainly happy to discuss these topics more if patients have specific questions. This is the part of my job that I really enjoy the most. And so thanks again for having me.
Thank you, Dr. Kelly. We truly appreciate you taking the time to do this this evening. I do have a couple questions, if you don't mind me asking. Talking to women in our community who are those types who discontinue their medications, they often say, I've already tried to, and it's just not the right thing for me. So what suggestion or recommendation do you have to those types of women who've tried a couple of times and the side effects were too much for them? I'm sure you get this a lot.
Yeah, and it's a wonderful question. It's a question we get pretty much every day in the clinic. So one thing I would highlight is that there's fairly compelling data to show that patients who have had struggles with one or even multiple cholesterol medicines are often able to tolerate some amount of one of the statins. As I may have mentioned earlier on, there are several statin medications, and they're all slightly different in their composition, the way they're metabolized. And so depending on what medication someone might be on or some other factors, we can often tailor a treatment plan to get someone on some amount of a statin. Now, look, there are some patients who, despite our best efforts, we're not able to, but we're fortunate to practice in a time where we have other medications as well that we will use to treat LDL cholesterol and other cholesterol disorders. And so in certain circumstances, we will reach for other medications, either to add on to statin therapy or to use on their own in patients who are unable to tolerate the statin medications.
Thank you for that. Also, you hear a lot about red yeast rice. Mm-hmm. I've had some patients in the past that swear that is better than, it's the best medicine. So can you clarify, give us some information regarding that? Because I've always gotten to discussions with women in our community about red yeast rice.
Yeah, absolutely. So it's a very common supplement that we see our patients come in on. What I will say about red yeast rice is the active ingredient in red yeast rice that leads to the cholesterol lowering effect is very similar to the compound used in some of the earliest statins. And so that's the reason it works. And I would say there is certainly some data for red yeast rice, and in certain patients, it is something to at least discuss, particularly based on patient preference and again, based on the clinical scenario. I think that the main sort of things to keep in mind about it, though, is it's not a pharmaceutical medication that is regulated by the FDA or other governing bodies. And so purity standards, composition, and so forth are important things to keep in mind there. And similarly, the amount of cholesterol lowering you'll receive from red yeast rice is fairly modest. And so again, depending on patient factors, patient preferences, and so forth, that may be acceptable. But in some of our patients, particularly our higher risk patients, we worry that that Medicaid or that supplement alone may not lead to the amount of cholesterol lowering that we would like to them to receive based on their risk. So that's what I would say about red yeast rice.
Okay, one last question. CoQ10, tell us about it.
Yeah.
Who should take it? Who shouldn't take it?
Yeah, so it's another, it's a supplement that is really fairly benign, not a lot of kind of concern about side effects in general. I would give the same caution as red yeast rice in the sense that it is not regulated by the FDA. So, concerns about purity standards and composition and things, I think are important, points to make or concepts to keep in mind. But in general, it's a fairly harmless supplement. The data for it is mixed. There are plenty of studies that say that there is actually no advantage of taking it. And I should take a step back and say the reason to consider it, or the reason it's often brought up, is not because it lowers cholesterol. That's not its purpose. But there is thought that it could actually help mitigate the risk of muscle side effects. Again, that most common side effect from statins by taking that, related to some of the effects that statins can have in certain parts of cells and so forth. So that's the idea behind it. The data, as I said, is mixed. Many studies show no benefit. There are some studies that show some benefit. I'd say at best it's a bit of a wash, kind of 50-50 with regard to what the data shows. I will tell you anecdotally, I have many patients who have benefited greatly from being on CoQ10. And so in my practice, I would say that if someone is worried about side effects or has had side effects, it certainly is something that can be discussed and considered after certainly understanding sort of where the data is. And it certainly is a bit murky with regards to the data, but it's a typically safe supplement. And so the harm or the potential risk is quite low. It's definitely something that can be considered in discussions with a patient's provider, especially if there are concerns about these side effects.
Thank you, Dr. Kelly. This has been very, very well done, and a lot of information that is, a lot of women in the community have asked tons of questions, and I think you've answered a lot of them this evening. So we want to thank you. For those in the audience, if you have any questions related to your heart health, virtual webinars, or would like more information on the Women's Heart Initiative, you can email us at mlhwomen'sheart@mlhs.org, or you can call at 484-476-3WHI. Also join our Facebook group. We want to thank you and continue to look for more webinars on our digital library. Thank you and have a good evening.